Hi, my name is Rex Marco, and I'm here to talk to you about the UTHealth Houston Spine Fellowship. The purpose of our fellowship is to try to give you what we think is an ideal program with a positive learning environment. And when I finished my fellowship, I thought there were some things that we could improve upon, like give you experience in all the areas of spine surgery, including degenerative conditions, deformity, trauma, tumors in the adult and pediatric population. And in doing so, we could provide you maximal surgical experience with in the clinic and the operating room, working on the spine from the occiput to the sacrum and pelvis, in the front and the back, using minimally invasive and maximally invasive techniques. The goals of our fellowship are to train surgeons who, like this quote says, do the right thing in the right way for the right reason. And this quote was said by one of the large implant company representatives on one of our past trainees. And as we mentioned before, developing a complete spine surgeon who's able to recognize and manage all the conditions that you may run into while taking care of patients with spinal conditions. We believe that every patient requires knowledge of deformity and regional and global alignment principles, especially when a fusion is to be done, whether it's a 1-level fusion or a 20-level fusion. Much like we have to memorize the fusion angles and alignment when we fuse the knee or the hip or the shoulder or a finger or a toe. It is important that knowledge of deformity principles and alignment at each appropriate level and individual level are kept in mind. And so studying these alignment principles before the operation and during the operation, and then critically evaluating them afterwards, are important for optimal results. Here's an example of some of the things we like to emphasize. It is important to realize that about 2/3 of the lumbar lordosis in general comes from L4 to S1. So if you take someone who has an average PI of around 60, 2/3 of that would be 40 degrees from L4 to S1. And importantly, about 2/3 of that lordosis for most people comes from L5S1, and 1/3 of that lordosis comes from L4-5. So if you take 2/3 of 40, that would be about 25 degrees, and 1/3 of 40 is about 15 degrees. And so in general, on average, most people who are younger would benefit from around 25 degrees of lumbar lordosis at L5S1 and 15 degrees at L4-5. Now there's some newer studies by Pacente and the group with Dr. Lafage showing that in older patients that this can change, and it varies based on whether there's a patient with a low PI, a medium PI, or a higher PI. And in their study, they showed that most people have a lumbar lordosis of around 35 degrees from L4 to S1. And so keeping that in mind, if you're fusing someone at L4-5 alone or L5-S1 alone, then considering putting a cage or restoring lordosis to about 15 degrees at L4-5 and 20 degrees at L5-S1 is something to keep in mind. And this quote comes to mind. Dr. Stephen Tice taught me this, that there are two types of spine surgeons, those that create deformity and those that treat deformity. And one of our goals is to help you become a surgeon who treats deformity rather than creates deformity. We do our best to create a culture that allows you to approach us. We know that you are our colleagues, and when we bring you on as junior faculty members, which has a lot of benefits for you as you mature to an independent practitioner. And we listen to your input and value your input and allow you to add things to your education as you see appropriate and make changes as we work together. And it is important to know that you're a wanted guest on our service. There's a difference between being wanted and being needed. I remember in my fellowship, I felt like I was needed to get the patient up and perform their physical therapy before rounding and before going to the operating room. And that's not our culture. We want you here. We don't need you here. And I believe that there's a big difference between wanting you here as a guest versus needing you here to do work for our patients and our service. And that's different than when you go look for a job. I think it's important to be needed more than wanted, because I took my first couple jobs and actually wasn't needed at those jobs. They wanted me to be there, but I wasn't needed. And so we also emphasize that when you do go look for a job, to try and find a job where you're both wanted and needed. Here's a little bit of information on the Texas Medical Center. It is the world's largest medical center, and we have the world's busiest trauma center, which is Memorial Hermann Hospital, where we are based out of. And you also have the option to rotate at the world's largest cancer center in MD Anderson Cancer Center. Here's a little bit of information on the Texas Medical Center. Multiple institutions. It's a city within a city. It's massive. There's a ton of research, millions of patient visits, thousands of surgeries, and billions of dollars of research funding. Here's a brief summary of our fellowship experience. We offer complex spine surgery and adult deformity education with Dr. Eric Kleinberg and Shah Dadwad, James Showery, and Cody Tillinghast. Our degenerative spine surgery and trauma surgery program is run by the entire adult faculty, as mentioned above, and our MIS, minimally invasive spine surgeon specialist, is Dr. Ran Lador. We give you exposure to lateral and anterior surgery with Dr. Park and Dr. Tillinghast and Dr. Showery and Dr. Dodwad, and our pediatric deformity group with Dr. Eric Kleinberg and Tim Borden, Shiraz Yunus, Lindsay Crawford, and Surya Mundluro. Our spine tumor experience with Dr. Lador and myself at UT, and Dr. Bird and Dr. Rhines at MD Anderson. There are approximately 300 cases that each of our fellows will do, but more importantly, it's important to look at the number of levels that you may see. For example, if you're involved in a case where there's an en bloc spondylectomy being performed, you will do a total of 4 TLIF operations, one on the left side, one on the right side, at the cephalad level, and one on the left side and one on the right side at the caudal level, as well as multiple laminectomies and multi-level spinal instrumentation, en-bloc resection of the vertebral bodies, and reconstruction of the anterior column and posterior column. And so even though that might be one case, there are multiple cases within that case. And if you look at this list, the exposure for you to minimally invasive surgery like microscopic discectomies and ACDFs, lateral approaches, T-lifts, those are all given to you, and including cervical disc replacements and anterior column realignment and A-lifts, corpectomies, importantly, image-guided surgery and freehand, as well as fluoro-assisted and navigation placement of pedicle screws, are all things that you will see while in this fellowship. In addition to a thorough and excellent surgical experience, we believe it is important for all trainees to learn how to practice in the clinic environment. And so on each rotation, you are able to go to the clinic at least once a week and sometimes twice a week. And what most of us found is that practicing in the clinic environment is much more difficult than doing the procedures. And so getting acclimated to this while you're in training is very important and useful. We are also able to give you an experience where you will have your own patients in clinic under my guidance, and so you can see your own patients and schedule your patients for surgery, and then operate on them as you see fit. We follow ACGME guidelines and GME milestones, and teach you all the things that many of you have a great background from your residency, but now you'll have the opportunity to practice more independently and see expert surgeons in their clinic as well. These are our rotations. At the top of the orange box, you'll see a list of all the attendings and their operative days as well as their clinic days. In the blue box, you'll see the fellow rotations, and fellow 1 will be operating primarily at Memorial Hermann Hospital and doing clinic once a week, whereas fellow 2 will be operating mostly at Memorial Rockets Orthopedic Hospital and doing clinic twice a week and having one administrative day. We do offer an MD Anderson elective option, and for most of you who choose to do this option, you will see patients with spinal column tumors and spinal cord tumors working with Dr. Rines and Dr. Bird, as well as all the other faculty at MD Anderson. We'll also have labs while you're there to work on en-bloc spondylectomy techniques, as well as transpedicular corpectomy and reconstructive option techniques in our Sawbones labs. And then you'll have the option to learn about less invasive spine tumor surgery, as well as radiosurgery and injections. Our didactics and conferences are robust and extensive. We have a lecture series on adult deformity, spinal trauma, pediatric deformity, spinal tumors, degenerative conditions, as well as spinal infections. We have a weekly case conference dedicated to teaching indications, as well as surgical technique and critical thinking and critical evaluation of how well you did in the operating room and what your postoperative x-rays look like, how you could improve on your techniques, as well as billing and coding. Learning about that is very important. We have a monthly skills lab where we teach you on sawbones and a monthly journal club. Our other conferences include a weekly orthopedic spine indications conference, a bi-weekly postoperative conference, a bi-weekly tumor conference, a monthly pediatric deformity indications conference, a monthly spine research meeting, and a quarterly combined neurosurgery and orthopedic surgery journal club, as well as a quarterly pain management and spine combined journal club. And every 4 months we have morbidity and mortality conferences. Research is a requirement, and we require that you have one submitted manuscript by the end of your fellowship. Our faculty members have numerous publications and experience with study groups, including the ISSG, or International Spine Study Group, and the AO Knowledge Forum study groups in deformity, tumor, and spinal cord injury, as well as spinal pelvic tumor study groups. And so our faculty have hundreds of publications combined, and Dr. Showery is in charge of leading our research directive and can help you get your project completed. We believe that it's important for you to learn different techniques to place pedicle screws. We have attendings with expertise at the freehand technique, as well as expertise with fluoro-assisted pedicle screw placement and expertise in placing screws under navigation. And through this, we believe you can learn all the different techniques and of placing pedicle screws, and when you go out into practice, you can decide which technique works the best for you in your hands. Here's an example of our fluoro-assisted technique, where we use these detachable pedicle markers and probes. There are Linky probes that you can use as markers and take one spot fluoro shot. And so in theory, with 3 x-ray shots of spot fluoroscopy, you can place 12 pedicle screws accurately with very minimal fluoroscopy use and radiation exposure to the patient, and no radiation exposure to the surgical staff. I didn't know this when I started my fellowship training, but I quickly learned as an attending that every single bone that you operate in the spine is different. The occiput is different than C1, and C1 is different than C2 on the front, in the back, from the side. Every bone is different. T1 is different than T2 and T3, and so learning what each bone looks like and the anatomy and the intricate differences between them is important and taught. Here's another example of what I learned. I didn't know the path of the vertebral artery as it was going through C2, and I didn't realize that it changed from patient to patient. And so this study shows the different variations within the patients, and what we show is that there's a safe zone to place a pedicle screw within the C2 pedicle in many of the patients, and some of the patients it's not safe to put a pedicle screw, and so maybe placing a pars screw or a translaminar screw might be of benefit in those patients. We have a monthly sawbones lab, and we started this after my accident, and I worked with many of the trainees in the sawbones lab in the operating room before my accident, and what I'm told is that they were able to pick up more tips and tricks about how to do the different operations, how to place pedicle screws and lateral mass screws and C2 pedicle screws and pelvic bolts. And they felt that it was more productive learning in the Sawbones labs. And my theory is that when we're in the operating room, that the learning environment there can be more like a panic zone type of learning environment. Whereas in the Sawbones lab, the trainees are in their stretch zone. And so when they learn in their stretch zone, it's more productive. And then they can go into the operating room and create a stretch zone of learning in the operating room compared to a panic zone of learning in the operating room. Our trainees have an extensive fund of knowledge when they complete the fellowship. I was with one of my trainees, and we were sitting at the International Meeting of Advanced Spine Technology, and literally every presentation that was given, we had talked about the different nuances of that updated presentation in our conferences. And so the knowledge base of the attendings and the discussions that we have in our conferences allow you to have an extensive amount of knowledge as you move forward in the rest of your career. We also feel it's important to teach you ergonomic and efficient and safe spine surgical techniques. We introduce you to things like the pneumatic kerrison, which can save your joints in your hand long term over your multi-year career. We use power to place our pedicle screws and expose you to this option, as well as the option of using a foot pedal bovie and a foot pedal burr, which can also save the joints in your thumb and your fingers. And in like this study we did, showing that the headgear that you wear can weigh down on your neck and put a lot of force on your cervical spine and cause many surgeons to have neck pain, and ultimately some of them get surgery. So different headgear options, and personally I'm averse to smoke in the operating room, and we introduce you to the option of using a suction bovie to decrease the smoke inhalation that you're exposed to. Additionally, we try to minimize radiation exposure to you as well as the patient, and teach you different techniques that will allow you to do that. We have expertise in self-care, and we can teach you about things that we've learned about emotional intelligence and mindfulness-based stress reduction to help avoid burnout, and techniques to help you achieve resilience, which is the ability to experience difficulty and come out stronger. Working with patients can be difficult because all of your patients are experiencing losses and grieving from those losses, and understanding their pain and their emotions, and where mindfulness techniques and narcotic cessation and smoking cessation techniques can help you and your patients in your practice, as well as learning to talk to your patients to help you minimize lawsuits in the future. One of the most important things that I've learned as a practitioner is to help build a team and work together and treat everyone with respect. And I've learned even more about that in working with Dr. Kleinberg, who is the epitome of working as a team and teaching teamwork and respect for everybody. And when you come here, I think you'll notice that it's an unbelievable environment. We have an unbelievable team that works well together and is respectful to each other as well as the trainees. One of our goals is to help you become an independent practitioner, and in order to do that, we feel it's important to bring you on as junior faculty with attending level privileges in the clinic, in the operating room and while you're on call. This way you can see your own patients, indicate them for surgery, bring them to the operating room, start and finish the operation. And of course we don't let you leaving you hang out to dry in the beginning, but we work to the point where hopefully by the end of the year you will be able to independently perform operations from beginning until end. Make your own decisions while you're on call on how to best treat these patients and whether or not they are best treated with surgery or without surgery. We give you extensive electronic medical record training and help provide you with different models to build your own team with a medical assistant and advanced practitioners like nurse practitioners or physician assistants. We have an excellent team of MAs and PAs and nurse practitioners, and you can learn from these excellent providers about what it's like to have a team and a team approach as you move forward and go out into your own practice. We also emphasize billing and have extensive experience with billing and coding, so we can help you with this as you're training during the year. We also emphasize that our graduates stay in communication with us throughout their entire career so that they can discuss any challenging cases coming up, and we also encourage you to come back and we can help you prepare for your boards. We recommend that our trainees attend cadaver courses throughout their fellowship as well as throughout their career to help expand their surgical experience and expertise. And we also offer labs in microscopic spine surgery, endoscopic spine surgery, as well as video-assisted spine surgery. There are numerous opportunities with the different attendings that we have to be involved in medical missions, as many of our surgeons have performed medical missions like in Haiti and Guatemala and Kenya. Where do our graduates go? 1/3 of our graduates are in academia, 1/3 are in private practice, and 1/3 are in privatemics. What are some common questions? Is there fellow autonomy? As previously discussed, there's graduated autonomy with the goal of helping you become an independent practitioner and surgeon throughout the year. Is there a non-compete? No, there's not. And will we be obtaining ACGME accreditation? We do not have current plans to do that, and instead we choose to help bring you on as junior faculty with attending level privileges. In terms of your benefits, Donna Bryant will provide you more information on the benefits. Weaknesses of our fellowship include the fact that we are a new fellowship. We have one rotation with neurosurgery, and we're hoping to get more rotations with neurosurgeons, and we do not have any current attendings who have expertise in robotic spine surgery. Houston is a great place to be for a year. We are a sports town. We have a lot of restaurants and a tremendously diverse culture, a lot of recreational activities and beaches and lakes. Are there any changes planned in our fellowship? We don't see any immediate changes, except we will be doing our best to work with the neurosurgeons more, and we will be recruiting faculty to expand our current faculty. And one thing that we've noticed is that things change when people are unhappy and people change. And we believe that most of our attendings have their ideal job, so it's unlikely that any of us will leave. Teaching surgeons to be the best that they can be is our passion, and creating the ideal fellowship training program is our primary goal. Here's a brief overview of our faculty. This is Dr. Kleinberg, and he is the Chip Rout Endowed Chair of Spine Surgery, and he did his fellowship at the Cleveland Clinic, and he's world-renowned as an expert educator and great overall guy. This is me. I trained at Memorial Sloan Kettering Cancer Center as well as Rush for my spine fellowship. And as you'll see, our attendings have trained at numerous places, like Dr. Kleinberg trained at the Cleveland Clinic, and I trained at Rush. We have several attendings who trained at Emory as well, and Northwestern, and the Campbell Clinic, and Texas Scottish Rite, as well as Boston Children's. Dr. Dodwad trained at Northwestern, and he's the director of spine trauma. Dr. Lador is the director of spine tumors, and he trained at the Rizzoli Institute in Italy, as well as MD Anderson Cancer Center. Dr. Showery is the director of spine research, and he trained at the Cleveland Clinic. Dr. Tillinghast is the director of spine resident education, and he trained at Emory. Dr. Park trained at Emory and is an expert in degenerative spinal conditions. Dr. Borden is the chief of pediatric spine deformity, and he trained at Boston Children's as well as Royal Children's Hospital in Melbourne, Australia. Dr. Eunice is another expert in pediatric spinal deformity, and he trained at the Campbell Clinic. Dr. Crawford is also one of our spine pediatric deformity specialists who trained at Arnold Palmer Children's Hospital in Orlando. Dr. Mandluru is another one of our pediatric spinal deformity specialists who trained at Texas Scottish Rite. Dr. Rhines is the director of the spine program at MD Anderson, and he trained at Johns Hopkins as well as MD Anderson for his spine fellowship. Dr. Bird is a spine tumor specialist at MD Anderson, and he is the director of the Ideas Lab at MD Anderson, and he trained at MD Anderson Cancer Center for his musculoskeletal oncology training and completed his spine fellowship at the Texas Medical Center Spine Fellowship. And that's an overview of our program, and I thank you so much for taking the time to come and visit us. And if you have any other questions, please feel free to contact us.